Alright, now we're going to go over Chapter 44, Pain Management Review. We're going to go over the stuff that we highlighted, and we're going to make questions about it. Alright, so tell me about acute pain. So we know acute pain is protective. Usually has an identifiable cause, lasts like a short amount of time, and it basically warns people of injury or disease. So we know it's protective. Eventually resolves with without healing. Usually once the injury heals, the pain's gone, which is good. And since it's has a predictable ending and identifiable cause, health team members are usually willing to treat it aggressively, which is kind of nice. Tell me about chronic pain. It's not protective and thus serves no purpose, but has a drastic effect on the person's quality of life. So some examples would be like arthritis, low back pain, headache, fibromyalgia, and peripheral neuropathy. Some of the symptoms of chronic pain would be, what do you think? Fatigue, insomnia, anorexia, weight loss, apathy, hopelessness, depression, anger, things like that. So, tell me what nociceptive pain is. It's like a normal stimulation of special peripheral nerve endings called nociceptors, usually responsive to opioids and or opioids. What are the two types of nociceptive pain? You got somatic pain, that comes from bone, joint, muscle, skin, or connective tissue, usually aching or throbbing in quality and well localized. And you have visceral pain, so it arises from visceral organs such as the GI and pancreas. Tell me about what is neuropathic pain. Abnormal processing of sensory input by the peripheral or central nervous system. Treat usually includes adjuvant analgesics. So tell me about here's just some common biases and misconceptions about pain. These are not true. People who abuse substances overact discomforts. This is not true. Some do, but not always. Patients with minor illnesses have less pain than those with severe alterations. Is not 100% true. Administering analgesics regularly to drug addiction is not 100% true. The amount of tissue damage in an injury accurately indicates pain intensity. That is not always true. Healthcare personnel are the best authorities on the nature of the patient's pain. Not true. Psychogenic pain is not real. Not true. Chronic pain is psychological. Not true. Patients who are hospitalized experience pain. Not true. Patients who cannot speak do not feel pain. Not true. So there's some factors that influence pain in older adults. We know they lose muscle as they get older, but gain fat as they get older. So the concentration of water-soluble drugs such as morphine increases. We know that. We know that they eat terrible. That means they're going to have more free drug in the body because they are highly protein bound. And then we already know that their liver and renal function declines with aging, so they have reduced metabolism and excretion of drugs. So then we know pain in infants. All these I'm going to tell you are going to be true. Infants have the anatomical and functional requirements for pain processing by mid to late gestation. Term neonates have the same sensitivity to pain as older infants and children, but preterm neonates have a greater sensitivity to pain than term neonates or older children. Although infants cannot verbalize pain, they respond with verbal cues and physiological indicators that are observable. Pain requires no prior experience. Infants don't need to learn it from painful experience. It occurs with the first insult. You use behavioral cues and validity to assess pain in infants, and you can give infants drugs. You just have to monitor and calculate the doses properly. So these are going to be true about older adults. Older adults are at greater risk than younger adults for many painful conditions. However, pain is not a normal part of aging. There's no proof that says pain's perception or sensitivity decreases with age. Older adults commonly underreport pain because they don't want to lose their sense of independence, stuff like that. Even though they may be distracted, doesn't mean they don't have pain. Opioids can still be given to older adults. You just have to give it low and slow, just the dose and stuff like that. No evidence that shows that patients with cognitive impairments don't feel pain. And older adults don't report more pain as they age. They actually underreport it. So there are possible sources for error in pain assessment. Things could be like bias, vague or unclear assessment questions, pain assessment tools used on the wrong people, using med terminology that patients can't understand, patients who does not provide complete, relevant, and accurate information, and then patients who are cognitively impaired and unable to use pain scales. And we know these tools identify the presence of pain but do not determine the intensity. So, tell me about superficial or cutaneous pain. It's resulting in the skin. It's short duration and localized, kind of sharp. So it's like a needle stick, small cut, or laceration. Talk about deeper visceral pain. It's pain resulting from stimulation of internal organs. It's diffuse and it radiates. Kind of be sharp or dull. So crushing could be angina pectoris, and burning could be gastric ulcer. Referred pain, we think the pain comes from one part of the body, but it's actually somewhere else, like an MI. It's in the chest, but the pain's actually like your jaw, left arm, left shoulder, stuff like that. And then radiating, it feels it traveling down a long part of the body. And severity is one of the most subjective and therefore most useful characteristics for reporting pain. Read this. We know behavioral indicators of pain. The primary goal of the nurse when it comes to pain is to improve what? Patient functioning. So concomitant symptoms are basically like symptoms that occur along with pain, but like if you have those symptoms, they're gonna basically make the pain worse. So you want to treat the pain as well as the symptoms at the same time. Basically, kind of important, equally important. So like if you have acute pain related to physical trauma, you might have to use a medication, whereas acute pain related to childbirth, you might have to use non-pharm like controlled breathing techniques. All right. You can read this if you want. So how do we control? You can read this to control pain stimuli in patient's environment. You can read this too. Shit, it's trash. Read this. Read this. Read that. Read that, baby. This is trash.